how do we classify interstitial lung disease, and how do we detect connective tissue disease in ILD? These are very challenging fields, and I think most of you are experts. Some of you are more expert than I am, and so it will be challenging, but nonetheless I would like to discuss with you this issue. And please interrupt me at any time if you disagree or if you want to add something, because I think we can make the best of this afternoon if we interact at the maximum. So you are very familiar with these slides. I think I presented these slides probably 100 times all over the world, and this is the classification of interstitial lung disease as made by ATS ERNs more than 10 years ago. So is this still something which is contemporary or useful in clinical practice? I think so, yes, in particular if you look to some established entities. This box, exposure-related disease, I mean, there is no question. They are not going to change that much over time. The same is for sarcoid. The same is for these entities. These we'll be talking about later, but this is the real black hole in this classification. Idiopathic interstitial pneumonia, what we mean about that. Which is the approach to the ILD patient? So this is my approach to the ILD patient. It can be different from your approach to the ILD patient. And I'd like to discuss this with you, maybe not with Professor Cordier, which is too much an expert of this, so I don't want to answer a question from him, but for anyone else, yes. So first, of course, you need to know about ILD. You need to learn, you need to study, you need to read, and to know that ILD is an entity and is a complicated entity. Then you take a history of your patient, lung function, and high-resolution CT scan. That's, I think, it's the minimum set of diagnostic tools that we need to make a diagnosis of IPF or of interstitial lung disease. And in many instances, you get the diagnosis after you take a detailed history, lung function, and high-resolution CT scan. So this morning we have seen the case of IPF, but there are many others. All the occupational exposure-related ILD, it's a mixture of history, lung function, and high-resolution CT scan. Sarcoid, most of the cases, they might be diagnosed even before BAL. IPF, we have seen that 50 to 60% of patients that will get diagnosed before lung biopsy. And Langerhans cell histiocytosis, or LEM, they have typical appearance and typical feature at high-resolution CT scan. You'll make the diagnosis at this stage. But in a fraction of this disease, this part is not enough. That means that you need to ask yourself, do I need bronchoscopy? Or it is possible that this patient has a non-obvious connective tissue disease. And these, I think, are two critical questions to ask yourself. Bronchoscopy. Which are the use of bronchoscopy? To rule out or to diagnose occult infection, to diagnose sarcoidosis with transbronchial biopsy or bronchoalveolar lavage, or a combination of the two, to evaluate the differential cell count for hepatitis pneumonitis, eosinophilic pneumonia. This is mainly common practice in Europe. It's not used that much in the US or the rest of the world. Diagnosis IPF by bronchoscopy, I don't think is feasible for the reason that we explored this morning. But some people, they think that bronchoscopy that can be supportive of a diagnosis of IPF. So it's clear that bronchoscopy needs to be performed at least in a fraction of these patients. And in a fraction of these patients, you need to do bronchoalveolar lavage. And I want to underscore how it's important for a pulmonologist to have a reliable reading of bronchoalveolar lavage results. You need to know which cells are there, the numbers, the characteristics, the phenotype, the proteins, and so on and so on. Now we go at CTD. CTD will be the talk, the next talk. I'm sorry, it will be short. What to send to diagnose a connective tissue disease is completely unclear. And even in the IPF guideline, is not explicit. They just tell you, you test for the possibility of a connective tissue disease. What we do, usually we test for RF and CCP for rheumatoid arthritis. ANA test, very non-specific at low titers. SSA, SSB for the Sjogren. JO1, CPK aldolase for myositis. RNP for mixed connective tissue disease. SCL70 for scleroderma. But we know that connective tissue disease may present without extrapulmonary manifestation. So you can be in the presence of a patient with only pulmonary involvement and still have connective tissue disease. And that's a very critical and difficult point that we'll address in the next talk. But let's say that you make a diagnosis of sarcoid by transbronchial biopsy, or a diagnosis of, let's say, Sjogren by serology, then you get the diagnosis. But this is not happening very often. In many cases, you don't have a diagnosis here, then you go to surgical line biopsy. So surgical line biopsies in ILD is not like surgical line biopsy in cancer, in which you have a definite answer to your questions. Surgical line biopsy in ILD can still be questionable. There is a lot of variability and inter-observer variability among pathologists, and the technique used to sample the lung of these patients, it makes a difference too. What we learned about interstitial lung disease, that is smoking, is the major factor for risk and also for categorization of this disease. Why is that? Because smoking is a major risk factor for many diseases, including lung disorders. Of course, emphysema, of course, lung cancer, of course, ILD. Just to remind you the importance of smoking, this is a very recent paper published in the New England Journal of Medicine by Richard Pito. You remember Pito and Fletcher, the curve on COPD change over time. You remember that? Good. And they published this important paper. And this important paper is actually showing that simply by not smoking, you gain 11 years if you are a woman and 12 years if you are a man. That's on average. That's a lot. I mean, that's the most convincing evidence to me for not smoking. It depends. If you like your life, you don't like your life. You know, if you have a horrible wife, or you don't like your life, you don't want to live for 10 more years. But at the same time, if you like your life, you enjoy living, you know, just by not smoking or smoking, on average, the difference between a common smoker and a never smoker is 12 years for a man and 11 years for a woman, which is a lot. It's really a lot. And this is another fantastic study, I think. You know, UK, the British are good for epidemiology, basically, not more else, but they are very good for epidemiology. And they did this study, which is a prospective study on 1 million women in the UK. That means something, right? And they showed very clearly, when you get the numbers to show this, that cigarettes per day, they correlate exactly with the expenses of life. And when you see a woman starting at less than 16 years of age, between 17 and 21, or more than 22, then the relative risk of dying as compared to never smokers, it declines, but never get back to never smokers. So again, smoking is such a powerful risk factor for any disease. Putting all together, that has a clear-cut effect on all of these disorders, including pulmonary fibrosis. You know, smoking increased the risk of pulmonary fibrosis at 1.53 times statistically significant. Of course, it's not the same risk as lung cancer or those, but still, there is a risk for these patients. So I think this is extremely important to know, and that's why I think it's important to understand this. So come back to this classification, and these are all smoking-related ILD, as far as we know. Rheumatoid arthritis ILD, Langerhans cell histiocytosis, eosinophilic pneumonias, IPF, DIP, RBILD, they are all smoking-related. So that means that even in the field of ILD, smoking has a prevalent and prominent role. That's why you already know this, but this is the new classification that has been proposed by JRU in this issue of clinical chest medicine for the smoking-related interstitial lung disease. It's very interesting. It's very important, I think. They propose a new classification. This new classification is the following. There are chronic ILD that are very likely caused by cigarette smoking. So if you don't smoke, you don't get the disease. RBILD, respiratory bronchiolitis with interstitial lung disease, desquamative interstitial pneumonia, acute pulmonary Langerhans cell histiocytosis, and that's it. So, if you don't smoke, you don't get this disease. That means that it's extremely likely that this disease is directly caused by smoking. Then the second category is acute ILD. You see the change here. We are talking about disease presenting acutely within few weeks or few days that might be precipitated by cigarette smoking. And this is not really recognized. And these entities are acute eosinophilic pneumonia, very dangerous, presenting in young smokers, pulmonary hemorrhage syndrome. Again, these can be precipitated by smoking within few days or few weeks by start of the smoking. Group 3 is what we think is more easily associated with smoking, which is ILD statistically more prevalent in smokers. That means they can be found in non-smokers, but smoking is still a risk factor. IPF is the prototype, but rheumatoid arthritis associated ILD is the other one. And then you have the group 4, which I think it's very intriguing because it's never entered any classification. Is ILD less prevalent in smokers? So we could say that in this group 4, smoking is protecting from getting the disease. And these are, not surprisingly, immune-mediated disease, because smoking is a local immunosuppressor. So you have two entities. The first one is HP, hypersensitivity pneumonitis, much less frequent in smoker than in non-smoker, and the second one is sarcoid. So this is the spectrum, I think, of the relationship between smoking and ILD, going from being a strong risk factor for having the disease to being a strong risk factor for protecting from having the disease. Now let's go to the major point of this talk. The major point of this talk is the classification of idiopathic interstitial pneumonia. Again, as I told you, is a little bit of a black hole because they are idiopathic. They have been called like pneumonia, which is not exactly correct. And they have been classified in year 2002 by ATS with the collaboration of the ERS. But this classification was largely based on pathology. So both the ATS and the ERS recognized that there was a need to revise this classification, because this classification was pathology-based and was not practical for clinicians. That's why ATS and ERS started about 3 years ago, this process of reviewing that classification, and there is an update of the International Multidisciplinary Consensus classification on IIP. You see how many people have been involved. We have more and more people on guidelines. That's because we want to have people from different parts of the world. You want to have people from different specialties. You want radiologists, you want pathologists, you want methodologists on that. So this was a very difficult and long process, but at the end, this classification is going to be published in the Blue Journal soon. And it's also based, as the previous IPF classification, on the GRADE methodology for evidence. We meet a couple of times. The last meeting was in Modena, which is my city, which was also the city of the last meeting of IPF. I think they're coming back because of the food, but not because of me. And the major result of this exercise was the following. The gold standard for IIP, not only for IPF, is the multidisciplinary discussion between pulmonologists, radiologists, and pathologists experienced in the diagnosis of ILD. So this means that if you are not having a chat, or if you are not discussing a case with your colleagues in the radiology department, or in the pathology department if you have a biopsy, it's very unlikely that you are respecting the gold standard for the diagnosis of IIP these days. So the multidisciplinary diagnosis is the key point. And this is the classification, the new classification of IIP. It's a very pragmatic classification. And I think it's a major result. You know, the people there were a mix of different continent, different nationality, different background, but all of them, they want to have something which is practical in clinical terms. So we have major category. The first major category is the following. Major IIP. Major in terms of prevalence, epidemiology, and clinical impact. Of course, the first one is IPF. So IPF is the major player of the major IIP. The second one is idiopathic non-specific interstitial pneumonia. So you know, I think, probably you are aware that non-specific interstitial pneumonia was a provisional category in the previous classification. It was like the pathologists, they don't know what to do with this. They put in this category, it's called non-specific interstitial pneumonia. So it's, and in the guidelines, 2002, they wrote clearly, this is just provisional, it's going to be changed soon. That never happened. Never happened. And now we know that INSAP, like IPF, is a distinct entity. So try to go behind the names, because the names are made by pathologists, and pathologists are just people spending all the day on the microscope. They're not practical, right? But if you go behind the name, you see there is IPF and there is INSAP. I don't like NSAP, but the pathologists that don't want to change it, but still is an entity. It's idiopathic, non-specific interstitial pneumonia. Is a diagnosis. RB-ILD, of course, is a major component of this group, and DIP. DIP is typical of smokers, as you know, is reversible, can be progressive, you know about that. Then, we have the major discussion about BOOP or COP. And you know, the Americans, they like the terms BOOP, bronchiolitis obliterans with organized pneumonia. Why they like the term? Because it sounds, well, BOOP, right? Actually, it doesn't mean anything. On the other side, the UK expert, they like COP. So I think you may remind that the definition of IPF what cryptogenic fibrosing alveolitis in the UK. They like the term cryptogenic instead of idiopathic. So in order to get a balance between the UK and the US, we used idiopathic here, we use cryptogenic here. Is there any difference between cryptogenic and idiopathic, Jean-François?
There is a difference.
That's why I ask you.
Cryptogenic means a hidden cause.
Right.
And idiopathic is a self-governing disorder.
Right.
The terms have some sense.
Correct. So we end up with this COP, which is actually excluding BOOP. So BOOP is not anymore in the classification. And when you have an organizing pneumonia, which is very clear-cut, it's very distinct pathologic pictures in the surgical lung biopsy, if you don't find any cause for this, then you call it cryptogenic. AIP is a very rare entity. Still there are cases, but it's extremely rare, overwhelmingly rare. Most of the AIP, actually, they are exacerbation of IPF, unrecognized. So you see the practical and pragmatic approach, major and rare. Major means you're going to find this disease in your clinical practice almost daily. Rare means probably they are patients you are not going to see. Then you have idiopathic lymphoid interstitial pneumonia, idiopathic pulmonary fibroelastosis, new entity, described first in Japan, but now becoming more and more recognized. And then, this is a major advancement, I think. You have some IIP which are unclassifiable after lung biopsy. So, if you have a patient discharged from your ward with a diagnosis of unclassifiable IIP, it doesn't mean that you are not able to make a diagnosis. It means they go into a category that we are not able yet to diagnose. Unclassifiable IIP now is an acceptable diagnosis for patients with interstitial idiopathic pneumonia. We discussed a lot on how to categorize this disease, and I think this, we used cartoon, we worked overnight, and that was a very interesting exercise. You don't see this exactly, but you see that this is the prototype of the new classification. You know, actually, after IIP, there is not pathologic classification. There is clinical classification. It's chronic, smoking-related, acute and subacute. And then you get the pathologic features. So the categorization is the following. 3 categories: chronic, smoking-related, acute, subacute. This is the clinical, radiological, pathological diagnosis, and this is what you find when you get a biopsy. But we want to make clear the point that the clinical behavior is what is driving your classification. It's not your finding of a pathology, but it's how the patient behaves. This is the first part of the most important table in the document. We have different categories. You see, these new columns is clinical behavior. Treatment goal, monitoring strategy. So it's a pragmatic clinical approach. It's not made for pathologists. It's not made for radiologists. It's made for clinicians. Some diseases are reversible and self-limited. Typical example are ILD. Patients stop smoking, they revert. The treatment goal is to remove the cause, stop smoking in this example, and in short term, 3-6 months, you confirm regression. IIP, they can regress. That's the first category. Extremely important. Second category is reversible, yes, but with some risk of progression, typically an SIP, COP, or DAP. So initially, you look for a response, and then you need to rationalize long-term therapy. Short-term observation, confirm response, they can improve, they will not revert completely, but long-term, you assure that the gains are preserved. They will not go back to the previous state, but still they will improve. Most of the NSIP will be stable with residual disease. And your treatment goal so far is to maintain the status. They will not improve. You want to maintain the status and do long-term observation to assess disease course. And this is typical of most of idiopathic NSIP. Then the two other categories is progressive, irreversible, with potential for stabilization. These are the so-called fibrotic NSIP. You want to stabilize this patient with long-term observation, and you get into the category of IPF, but also some NSIP. They will progress, irreversible despite therapy. Your aim here is to slow progression, not to reverse the disease, not to stabilize the disease. You want to slow the progression. That's a realistic treatment goal. And you do long-term observation to assess disease course and the need for transplant or effective palliation. So, which is the summary of this new document? NSIP is now much better defined as an entity. It's not a bean, it's not provisional, it's a definite disease. Smoking-related ILD are an important part of IIP, but they are diagnosed without surgical lung biopsy. There was a lot of discussion, should smoking-related ILD be part of the idiopathic interstitial pneumonia if we know the cause, right? It's not idiopathic if you know that it's smoking-related. But at the same time, we decided to keep smoking-related within this box. About 10 to 20% of your patients, you will not be able to classify them. This is something that you have to live with. Unclassifiable IIP is a diagnosis. So the classification based on disease behavior, it's very important because it is independent from pathology and is clinically relevant. The last recommendation of this document is that molecular markers should be investigated to help diagnosis, prognosis, and treatment. So Bill Travis, who is pathologist in New York, he is the first author of the new guidelines on adenocarcinoma. He was very convinced that by translating molecular markers to IIP, we should be able to achieve results as in adenocarcinoma when we decide treatment strategy based on molecular markers. Are we there now? Maybe not, but this is where we should go. This is the lung adenocarcinoma classification, and if you have a patient with lung adenocarcinoma, there is no way that is not having all of these molecular fit, no? Should. Maybe. We don't know. But in any case, there are molecular targets that need to be investigated because some drugs will be effective, the prognosis will be different, and in the biopsy, you need to assess this. Are we there already with IIP? Not yet, but we're starting. We're starting. This is a paper from the group of David Schwartz in Denver, and he showed actually that MAC5B, which is a gene involved in the production of mucin, is a strong predictor of IPF in smokers. So I think we are moving forward an era where molecular testing will be more and more important, And I will leave you with this cartoon that will show you and stress the importance of molecular testing and genetics in daily life. Thank you very much.
Thank you. Thank you, Luca, for this excellent review. Is there any questions? Yes, please.
Thank you. Can I ask about the difference between fibrotic NISP and IPF? You know there are a lot of similarities in the behavior and the histopathologic features.
Yeah. The main difference is a pathology difference, and the main difference, if you discuss that with pathology, is that NSIP is a homogeneous disease, while IPF is UIP is a heterogeneous disease in terms of involvement. I have patients with this sort of fibrotic NSIP, they have the same behavior as IPF patients. So I think that we are in a field where you have gray zones and transition from one to each other. So it's very difficult to answer your question. That's why clinical behavior is what is important. So you have a patient with an SIP. You treat the patient with a short course of corticosteroid. If the patients improve, okay, that's a reversible IIP, and your treatment goal is completely different if the patient is keep deteriorating. So what I'm trying to telling you is that the pathology has a big role, but at the same time what it matters is the clinical behavior of these patients. So if you ask me which is the difference between fibrotic NSIP and IPF, UIP, if I'm a pathologist, I'm telling you there is a huge difference. If I'm a clinician, I'm telling you there is no real difference, in fact.
Thank you, Professor. A practical question that we face a lot of times, you did mention in that category the identifiable causes, drugs, for example.
Right.
We get faced a lot of times by consultations from the cardiologist telling us, we think this guy has interstitial lung disease that's amiodarone induced.
Right.
And the problem is, how can you confirm?
Yep.
Because even if you take a biopsy, the changes are going to be even in a patient that's not
Non-specific.
toxic.
Yep.
Right, exactly. So how do you confidently make the diagnosis and tell them, no, it's not the case?
That's extremely difficult. If you look, the French colleagues, they have this pneumotox website in which they update every single report of one single case, maybe related to one single drug. So that you ends up, I do that all the time with my fellows. You have a patient in front of you with interstitial lung disease. This patient is 65. He takes at least 4 or 5 drugs. You put one of these drugs into pneumotox, you tell it, yes, there has been a report from Korea showing that you have some. Now, the cause effect is very difficult to show. But at the same time, some drugs, they are clearly related to interstitial lung disease. So some of them, at least, they need to be taken into account and be discontinued to see if there is the cause.
Yeah, with the amiodarone, I was under the impression, that's one of the tips that one of my professors taught me, that if you do a CT scan without contrast on those patients, and it does light up, that may be a clue that it is amiodarone induced.
Even BL can be helpful, right? I'm looking at Jean-François who has much more experience than me. I mean, sometimes in BL fluid, you can find typical features of amiodarone-induced lung disorder. But the real point is that in any case, drug-induced ILD will always be based on your hypothetical link between the drug and the disease.
Thank you very much for your talk. Just to speak about a point to give credit for the North Americans, when they classify BOOP as BOOP, basically they are describing the pathology, bronchiolitis obliterans. My question is, whether it's BOOP or cryptogenic or whatever it is, wouldn't it be easier to classify them as, from the practical point, as steroid responsive versus steroid unresponsive?
This is one thing that has been discussed. But if you look at the classification, the fact they are responsive or reversible They are reversible after steroids, actually. So it's not written in the document, really, but it's what happened, right? So that's it. So they are steroid responsive or non-steroid responsive. So that's exactly what it means. But there are two critical information here. One, you need to assess the effect of your treatment early. Everything is 3-6 months. Second, it makes no sense. You have to avoid to keep going on chronic corticosteroid treatments if patients are not responding. I don't know which is your experience, but my experience in Italy is that patients, they keep going on corticosteroids for years without any evidence of response, just because it's the only available option. So this is something that the new guidelines strongly recommend against doing.
We move with similar interest to the second interesting subject, connective tissue disease and ILDs.
Thank you. This it will be quick. You will have no pain. But this is, to me, is one of the most difficult areas for a pulmonologist. First, because you need to interact with rheumatologists, and that's a pain. I mean, at least for me, it's not easy. And secondly, because you have a degree of uncertainty which is huge. So I try to figure out this presentation based on my daily clinical practice. CTD is a universe. Connective tissue disease is really a huge constellation of different patients, different disease, different definition, different categorization, different prognosis, it's very diverse. It's huge, connective tissue disease. But within connective tissue disease, you have some of these, they have respiratory symptoms. So that's an easy classification to me. As a pulmonologist, I will only care of patients with connective tissue disease and respiratory symptoms. Can be cough, can be dyspnea, can be anything, but they have to have respiratory symptoms. However, sometimes our radiologists, they take a high-resolution CT scan in a patient with scleroderma. Nobody knows why. And they find chest imaging abnormalities. The patient is fine, no symptoms, normal lung function, but the CT scan is abnormal. That's a major problem. That's a major problem, because what to do with these patients? And on the other side, these are patients with non-ILD. You ask yourself, does this patient has any subtle underlying undiagnosed connective tissue disease? In particular, she's a woman, she's 55 years old with some rhino phenomenon. So the spectrum of connective tissue disease and ILD is very wide, and it goes from rheumatologists just taking high-resolution CT scan in patients with established connective tissue disease to pulmonologists dealing with patients with non-ILD, and they ask themselves, does this patient have connective tissue disease? So how do we deal into these dilemmas? So I try to put some questions that, to me, as a pulmonologist, they are critical. So my patient has a connective tissue disease and chest symptoms. Why should I worry about that? Well, the patient is on treatment, the patient has a diagnosis of connective tissue disease. Why should I worry about that? This is why I should worry about that. This is cause of death in rheumatic disorders, rheumatoid arthritis, sclerodermas, lupus, myositis, Sjögren. If you go to pulmonary, you see that up to 60% of patients with scleroderma, they will die because of the lung disorder. So in other words, lung involvement is the major cause of death for patients with scleroderma. But that's also true for myositis, that's true for Sjögren. So we need to be aware that pulmonary involvement is a major cause of death in patients with rheumatoid disease. That's why when you pick by chance a patient with connective tissue disease, an abnormal high-resolution CT scan, you should worry. Because it's very likely that that abnormality is going to be the cause of death in that patient. So in connective tissue disease, the presence of a chest disease is associated mainly with more respiratory symptoms. The patient gets more dyspnea. Their impaired functional status, they're less efficient in the daily life. The quality of life is lower in patients with lung involvement and connective tissue disease as compared to patients with connective tissue disease and no lung involvement. And lastly, the greater healthcare utilization. They get for high resolution CT scan, they get for 6-minute walking test, they get for lung function test, and all of that. Finally, as we have seen in the previous slide, they live shorter. So, in other words, when you or your rheumatologist, they find lung involvement in connective tissue disease, there is a good reason to worry about it because of all of these reasons. The next question is the following. My patient has a connective tissue disease and respiratory signs and symptoms. What is their cause? It's not an obvious answer to this question. It's not that always the respiratory symptoms are directly related to connective tissue disease. If you look at the table, this table that has been drawn by many publications in the field, connective tissue disease and the lung, in rheumatoid arthritis, lupus, scleroderma, polymyositis, dermatomyositis, or Sjogren, in all of them, you can have infection being responsible for respiratory symptoms, and the drugs that are used to treat connective tissue disease, they can all be responsible for lung disorders. Not only, then you have the interstitium, the vasculatures, the airways, large and small, the pleura, the thoracic cage, they can all be involved in all of these diseases. So it's very clear-cut that it's impossible for a rheumatologist not to deal with a pulmonologist, that it's impossible for a pulmonologist not to deal with a rheumatologist. The respiratory symptoms in connective tissue disease, they come from the lung, they can come from the heart, of course, and sometimes they come from the esophagus in patients with scleroderma. So, does it matter that the patient has CTD and symptomatic lung disease? Yes, it doesn't matter a lot. Because you see, survival is shortened in rheumatoid arthritis patients with lung involvement. Okay? So, if you look at these slides, these are patients with lung involvement in rheumatoid arthritis, and they live shorter. And these are data from the group of Kevin Brown in Denver that has been submitted, not yet published, going to be published soon, is that if you look at patients with rheumatoid arthritis ILD as compared to the RA cohort or H-match cohort, this is a patient with rheumatoid arthritis without interstitial lung disease, and these are patients with rheumatoid arthritis and interstitial lung disease. So that's very clear-cut that they live shorter. That means that you need to give to these patients a prognosis which is shorter than patients without the disease. So, have we been able to target the lung disease associated with connective tissue disease? The short answer is no. We've not been able to do that. If you look to the rheumatoid arthritis-associated mortality rates between 1988 and 2004, the decline was 21%. And in particular, it was 34% in men, is reflecting that the therapies that we use for rheumatoid arthritis in general are effective. But if you look at the rheumatoid arthritis-associated ILD mortality, the mortality rates, they do not decline, they increased in the same period. So this means two things. One, that our colleagues rheumatologists, they have been able to manage very well with rheumatoid arthritis in the absence of lung involvement. But when lung involvement is present, the current therapies for rheumatoid arthritis doesn't work. Not only, but the mortality actually increased over the last 20 years. And this is a reflection basically of the use of high resolution CT scan, the prevalence of rheumatoid arthritis ILD also increased. So this is not clear-cut if this is a true increase in prevalence or it's just a better diagnosis by more use of high resolution CT scan, but nonetheless, there are more and more patients with connective tissue disease and ILD. And these patients are not treated by the current treatment for the underlying disease. And this is very clear-cut. These are data from our group in Modena, these are our rheumatologists. The impact of ILD in scleroderma is also important. These are all scleroderma patients, and this is the survival of patients with ILD and scleroderma. That's clear-cut, that the lung is the limiting organ for the survival of these patients. So my patient has a connective tissue disease, and chest imaging is abnormal. However, no respiratory symptom. What should I do? What? PFT, wait. So the frequency of abnormality at chest high resolution CT scan in connective tissue disease is extremely high. So the point that we call these abnormalities, what does it mean? Is that a disease? Is that just something that we pick up with a very sensitive tool, which is high resolution, no clinical relevance? So the point of PFT is a crucial one. But again, if you take a high resolution CT scan in the typical patient with rheumatoid arthritis, all of them will have abnormalities on CT scan. What do you do with that? This is what I'm considering doing. You need to determine the clinical significance of the finding. It's not that a report from your radiologist of reticular opacities in your patient with connective tissue disease is making you change your behavior. You need to assess the clinical significance of that finding. You need to evaluate symptoms. You need to determine the extent of abnormality, and of course, pulmonary physiology is a critical point. But gas exchange with activity is also important, and most importantly, I think, you need to follow over time. So the major point here is that if you find a patient with connective tissue disease and high resolution CT scan abnormality, do not forget about him or her. You need to follow up that patient, because in that patient, that lung involvement can be the cause of death. You know, the predictors of mortality in scleroderma are FVC and the extent of pulmonary fibrosis on chest radiograph. FVC percent predicts survival in scleroderma. So again, lung function is extremely important in this patient. And when I see patients managed by rheumatologists, they don't take any lung function, I'm really worried about that, because they cannot predict the prognosis of these patients. And also high-resolution CT disease extent predicts survival. This is a study from the Brompton showing very clearly that the more extensive is the involvement in high-resolution CT scan, the shorter is the life expectancy for this patient. And they propose this categorization, which what we are using now in our center: high-resolution CT scan extent, FVC combination, limited disease, extensive disease. At least you are able to predict the prognosis of these patients. And if you want, you may try some more aggressive therapy. If a patient has an extensive disease, he's going to die early. Why? Because we know very clear-cut that simply by assessing FVC and disease extent at high-resolution CT scan, you can predict the mortality of these patients. That's very clear. Now, one of the last questions, which is critically important. My patient has interstitial lung disease. It is due to connective tissue disease? That's one of the most difficult questions in my clinical practice, which is going together with this further question: what laboratory findings suggest a connective tissue disease to a pulmonologist? None to me. But if you deal with the rheumatologists, there are many of them. And this is extremely important and difficult area. This is a study by Ari Fisher, he works in Denver, showing that the low-level ANA titers, they are very non-specific, and they can be found in up to 25% of patients with IPF. Are they different from patients without ANA titer and IPF? Probably not. So that means that all of these testing are okay. They may be useful, but they are completely sometimes non-specific. And this is a study that has been published in 2009 against specific antibodies against rheumatoid arthritis in patients with ILD, again showing that these autoantibodies, they can be quite non-specific in the clinical practice of patients. One of the last questions: if you look at the high-resolution CT scan, is there anything suggesting you that this disease can be related to connective tissue disease? Yes. Yes. So these are idiopathic interstitial lung disease, a connective tissue disease related, and you see very clearly that the CT diagnosis is different. There are more NSIP in the connective vascular disease, but this again is a clinical diagnosis. When your patient, so when your radiologist, it tells you maybe it looks like an NSIP, which is a long jump, always be suspicious about an underlying connective tissue disease. You see, the imaging of NSIP is very typical, in particular when you compare that to UIP. So there is definitely more ground glass, more consolidation, more traction bronchiectasis, no honeycombing for NSIP, and that's as a suggestion for an underlying connective tissue disease. So this is idiopathic versus connective tissue disease related subtype, and you see that they are completely different in terms of survival. Anytime that there is a connective tissue disease underlying your ILD, even in the absence of treatment, the prognosis will be better than in patients with idiopathic pulmonary fibrosis. Some signs, sometimes they are overlooked by the radiologist, but you look here, pericardial effusion and pericardial thickening, they are much more frequent in patients with connective tissue disease as compared to patients with idiopathic. And this finding, which is usually overlooked, some pleural effusion, it may be very sensitive to tell you that maybe that patient is not an idiopathic, is not a typical IPF, but has some sort of underlying connective tissue disease. Of course, esophageal dilatation, in particular in patients with scleroderma, is something which is strongly suggested. So again, when you look at the high-resolution CT scan, don't look just at the parenchyma, right? You look at the pericardium, you look at the pleura, looked at the esophagus, because there might be some hint that that disease is not idiopathic. So this is my last slides, and I want to try to, this is a scheme that has been proposed by Ari Fisher and Ron Dubois in the Lancet last year. When you get a patient with an interstitial pneumonia, the first thing that you have to do, look for known cause. We're talking about drugs, okay, difficult, exposure, but not connective tissue disease, but known cause. This is the first category, and you need to exclude this patient. You need to find out this patient. Then, you have no connective tissue disease features, typical, antibodies, or connective tissue lung pathologies. In this case, you are in the realm of idiopathic interstitial pneumonia, because there is nothing that you can use to tell this disease is non-idiopathic. So that means that you have to look for the physical, the extra pulmonary feature of connective tissue disease. Maybe you take a capillaroscopy, or you look for some disease, you look for the antibodies, or you look for the pathology, and when you get the pathology, your pathologist tells you, look, there is nothing suggesting a connective tissue disease, like lymphocytes or lymphoid granulomas or so on. Then you have clinically features of connective tissue disease and positive autoantibodies, very clear. You have definite CTD ILD. In this case, the therapy is the therapy of the connective tissue disease. If it's scleroderma, it's the therapy of scleroderma. If it's rheumatoid arthritis, the therapy of rheumatoid arthritis. If it's lupus, it's the therapy of lupus. Last box, which is a gray zone, of course, there is no connective tissue disease specific features, but you have positive autoantibodies. It happens very often. In this case, you have a possible connective tissue disease, ILD, and Ari Fisher is now proposing this new entity, which is a lung-dominant CTD. Huh? You like it? You love it? That's very worrying. So, what is LD-CTD? Lung-dominant connective tissue disease means that you have a connective tissue disease which is only in the lung. Very difficult to diagnose, and probably is a spectrum between the classical CTD-ILD and the classical idiopathic. So for the time being, the recommendation here is that when you find a patient like this, you follow the patient over time. Because many times the patient will switch this way or this way. We don't know if this ILD-CTD is an entity, or it's just a transition because we pick up autoantibodies with no meaning, or very early in the transition to this. But at the same time, I think it's important to recognize that with some patients, it's impossible to put them in this category or this category from the beginning, and it's much better to keep them in this mid-category and see what happens with follow-up. Thank you very much.
Thank you for this very practical presentation. We may take 2 or 3 questions if you want.
Thank you again, Professor. 2 questions. One is probably your thoughts. Do you suggest that if we collaborate with our rheumatologists, that we should get baseline high-resolution CT scans and pulmonary function tests, especially that a lot of those patients are young, they're usually without any known pulmonary disease, and the range of normalcy in the spirometry, at least, is quite wide. So, yeah. You know what I mean? And this is a restrictive lung disease, if at all. So do you suggest, is it cost-effective to get a baseline so that we can compare them to themselves later on, should they develop whatever on their scans?
I definitely suggest to have baseline lung function, that's for sure, including the LCO, of course. In terms of a high-resolution CT scan, I think it's useful. You need to be prepared that in most of these patients you will find some abnormalities.
I'm talking about patients that have no symptoms.
Okay.
But at least
even
you can use them to compare them in the future to
even in
themselves.
patients with no symptoms. If you take a high-resolution CT scan, you need to be prepared that at least in a significant fraction of these patients you will find some abnormalities. Now, what you do with that? You take a lung biopsy, you move forward. So I think that if you are prepared to manage the results of these investigations, they need to be done. The starting point is crucially important, in particular for lung function, because you want to know if these patients deteriorate, in particular in the LCO. Now we get into the point of the LCO being variable, not reproducible, and so and on and on. But in the same center, taken by the same clinician, same technician, I think that in the end, it will be the most reliable and sensitive sign of lung involvement in patients with CTD.
A quick second question. You did show us clearly that the connective tissue disease, say RA-related interstitial lung disease, they fare worse. And the treatment is a treatment of the rheumatoid problem.
Yeah.
So they fare worse because the ILD does not respond to the usual RA, or because the treatment is not maybe, well, I don't know, robust enough or solid enough, or should we?
Actually, we don't know. So far we know that the treatment, the standard treatment for rheumatoid arthritis is not impacting on ILD, associated rheumatoid arthritis. I hope that in the future there will be trials addressing patients with ILD RA, but for the time being, I think that patient with interstitial lung disease and connective tissue disease associated is a huge challenge for us, because actually we don't know how to treat them. And we use the treatment with the standard treatment for the underlying disease. The point is that, as you have seen, it's not going to be effective. So there is clearly a medical need there, and I hope that future drug will address this population of patients. But so far, there is nothing that you can do.
Yeah, my question about also the same point. Like most of these patients are already diagnosed with with connective tissue disease, and then after a few years they develop interstitial lung disease. So if they were referred to us and we diagnose them to have ILD and we want to treat them, they are already received tons of steroids and they are already on immunosuppressive. So what else extra to add? And the question comes like about the new biologicals. Some of these biologicals have been used in sarcoidosis, ILD. So do you think the new biologicals of these connective tissue disease may be more helpful in connective tissue disease related ILD?
It's possible. You know, the so-called biological agents like the anti-TNF alpha agents in sarcoid, they have not been extremely successful. They did not resolve the problems. But I think that what is very clear from what we have, there is a need for new drugs, a new approach. So you're right that most of the patients coming to you as a pulmonologist with ILD, they have been treated with corticosteroids, cyclophosphamide, azathioprine, and so on and so on and so on. Again, these drugs have not been proved to be effective in these patients. So that's why we think as a community we should move forward and test new drugs in the properly assessment of placebo-controlled trials. Because so far, I think the treatment for these patients is not successful. It's not enough.
In a patient who has rheumatoid arthritis and he is treated by methotrexate, for example, how can you decide if the ILD is due to the medication or to the disease itself? Because if we stop the treatment and it's not the culprit, it will be dangerous for the patient.
What I do if the treatment has been prescribed by the rheumatologist, I blame the rheumatologist. It's his fault and that's methotrexate-induced interstitial lung disease. But in reality, there is no way to assess that. What I can tell you, I had a few patients like that, and if a patient develops interstitial lung disease during methotrexate, that's already a good reason to stop methotrexate for two reasons. One, because methotrexate is not stopping from developing ILD, and secondly, because maybe methotrexate is inducing the ILD. So that's a good point for switching to a different drug. In order to be 100% sure if the drug has caused ILD or ILD is part of the rheumatoid arthritis, that's almost impossible, of course.
Excuse me, the response of the non-specific interstitial pneumonia due to a CTD or to the idiopathic, do you think there is any difference?
That's a very good question. So NSIP has been defined, again, as I told you, as a provisional category. So the non-specific interstitial pneumonia was anything not classifiable as UIP or as HP or as sarcoid. So it's just like, I don't know what it is, it's something else. That means that an SIP diagnosis applies to different entities. You can find an SIP, of course, in connective tissue disease and in idiopathic NSIP. My feeling is that the pathology classification in ILD is not definitive. So NSIP in connective tissue disease can really behave differently from an SIP in the idiopathic context, in terms of response to therapy, in terms of prognosis, and in terms of what you see on clinical ground. So, again, we are not like in lung cancer. In lung cancer, you get your pathologist telling you adenocarcinoma, that's it, done. No question. Maybe you can do molecular things, you can do hybridization, you can do polymorphism or mutation. But that's adenocarcinoma. When your pathologist tells you NSIP, it's just telling you something which is part of the information that you need. Then you need the information from radiology, from the clinical, from the history of the patient, and from the prognosis. That's why the new IIP classification is taking into consideration, into the classification, the 3-6 month behavior. So I think NSIP can be different in the context of connective tissue disease and idiopathic.
You think it's better when it's due to CTD?
As far as we know, any ILD associated with connective tissue disease has a better prognosis than any ILD with no known disorder, no cause. But that's just the, you know, it's a statistical evaluation from large cohorts retrospectively evaluated. So in general, patients with connective tissue disease and ILD, they behave better than patients with ILD and no cause of ILD. But that's very general. I don't think it can be applicable to the single patient.
Thank you again, Professor, for this rich discussion. Thank you all.